Hello, I'm here with Associate Professor David Szmulewicz from Victoria, neurologist. And today we're going to talk about the neurospecialties, because often there's confusion around who does what. And we're talking specific about neurologists, neurosurgeons, neuropsychologists, neuropsychiatrists, and essentially when to use which specialty for what purpose. So thank you for clearing up the issue for us, Dr. Szmulewicz. Where would you like to start? Which neuro shall we begin with?
All right, so look, let's begin with neurology. So neurology is the specialty that covers the brain, spine, and nerves. Conditions that most people will be familiar with. So for the brain, there are brain injuries or diseases such as Parkinson's. For the spine, there may be traumatic injuries to the spine, such as suffered in a workplace accident, or illnesses such as MS. And then for peripheral nerves, most people will be familiar with the old-fashioned term sciatica, which affects one of the very long nerves in the leg and causes significant pain. So neurosurgery, as the name implies, is a surgical specialty, and it also deals with conditions of the brain, spine, and nerves. Conditions of the brain where neurosurgeons may be involved will include tumours, where they may operate to remove the tumour, or a head injury, where there may be bleeding into the brain, and so the surgeon may operate to remove the blood that's collected and so reduce the pressure. Traumatic injuries of the spine, where again the surgeon may operate to relieve pressure, for example, from a broken vertebral bone. And again, peripheral nerves, we can use the example of the term sciatica, where it's being caused by the nerve being compressed or squashed as it exits the spine. So next we'll talk about neuropsychiatry, which is really the interaction between neurology and psychiatry, and deals with the psychiatric, so the cognitive, the thinking, memory, as well as the affective, so the mood and feelings that can be seen in neurological conditions, particularly chronic neurological conditions, such as those that follow on from an acquired brain injury or certain chronic diseases. Now, the last of the neuros, so to speak, is neuropsychology, and that is really a modality that looks at very carefully testing the various functions of the brain, particularly around cognition, so thinking, memory, concentration. And when a person sees a neuropsychologist, they will have a very detailed battery of tests with a relatively objective assessment made. And this is often particularly helpful in teasing out what is the result of the organic brain injury, so the actual trauma, and what is a response to the injury itself. So how is the person dealing with that injury? And often in the case of a traumatic injury, there may be an element of post-traumatic stress, and this can overlap somewhat with the organic brain injury and be difficult to tease out. So it's often helpful to have these assessments. Now, in terms of who you would refer to, in the case of an acquired brain injury, such as a traumatic car accident or workplace injury, patients will often see the neurologist to have the brain and any spine or nerve impairment assessed. They will also often see a neuropsychologist if a cognitive component is identified. And then if there is an emotional component suspected, then a neuropsychiatrist or a psychiatrist. On occasions, a neurosurgeon is involved, and that's not necessarily because there's a question of surgery, although this is somewhere where they can be helpful, but it also gives a slightly different perspective, particularly on traumatic injuries. Now, it can be difficult initially to know where to refer to. So it is not uncommonly an iterative process where the patient may be sent to a neurologist who identifies a cognitive component to the injury and then may make a suggestion that the patient is sent on to a neuropsychologist to further detail that cognitive impairment. And then, for instance, a mood or emotional component is identified and a psychiatrist or a neuropsychiatrist is involved.
It is tricky. I know, we're getting more and more concussion, ABI kinds of requests come through, and, providing that distinction between when to engage a neurologist versus, as you say, neuropsychiatrist, who could also look at the emotional overlay, but potentially the cognitive as well, is always a tricky one. I think the other difficult one for referrers who, common presentation, general back pain. When would you recommend neurologist versus orthopedic surgeon versus neurosurgeon?
Yeah, so I think it's fair to say that a neurosurgeon or an orthopedic surgeon who specialises in spinal surgery would be equivalent. So we can think of those two as both being spinal surgeons. They come from a different background, but they work in the same area. And they will be particularly good at answering questions around surgical techniques and the appropriateness of surgical techniques, as well as of course, rating the impairment. There is some overlap, so patients are often sent to neurologists as well to get that sort of dual perspective to maximise the information. And so what's not uncommon is that the patient will see a neurologist and neurosurgeon or orthopedic surgeon who works in the spinal space.
Yeah. Okay. So as a neurologist who frequently undertakes medico-legal assessments, where are some of the areas where I guess you get sent injuries that may not come under your banner? Where are some of the common traps and pitfalls, or alternatively, they don't come to you as a neurologist and potentially they should have?
Yeah, so look, I mean, neurology is very broad as a specialty in general. So if a patient really has any symptoms that are referable to a brain injury, for example, then I think that you can't really go wrong sending someone to a neurologist. In that case, though, I think that what's most efficient is to arrange a neuropsychology assessment beforehand, so that when the neurologist assesses the patient, they have the formal neuropsychologist's assessment. So an important thing to say is that neuropsychologists, depending on the jurisdiction, are not able to formally rate injuries, but as neurologists, we rely quite heavily on their assessments because they do so in much more detail than we do. So it becomes, if you like, another piece of the puzzle or modality, like an MRI, that we rely on when we're formulating the patient's impairment assessment.
Okay, I've got one final curly question for you.
Yeah.
Post-concussion syndrome, where does that fit in?
Yeah, so this is a very topical area, and there are somewhat divergent views. I think the important thing to think about is, has the person had a brain injury? And that may sound silly, but the first thing we look at really is the mechanism of injury. So is there adequate proof that the patient could have suffered a brain injury? And if so, what's the likely magnitude of that? So is there evidence that the person really had a good knock to their head, got thrown out of a car, went through a windscreen, or was it the case that really they had a degree of whiplash, and yet a year down the track, they're talking about cognitive impairment. So then the next thing we go on to do is take into account the time frame, and the usual rule for an acquired brain injury is 2 years from onset. In terms of maximising the patient's recovery. So that's important in terms of the question of stabilisation. So sometimes it's important for a patient to be assessed earlier because they may be eligible for earlier compensation, but sometimes we get sent people a little bit too early. And we have to say that reassessment at least 2 years post the traumatic event will be required. And then there's this continuum of concussion, post-concussion, the ongoing impairment from a serious brain injury. And the post-concussion syndrome is somewhat contentious. Some people believe that it lies fully in the realm of a psychological or psychiatric diagnosis, while others believe that it is the sequel of a brain injury. And I think, it really depends on whether there's adequate evidence that the person suffered a serious enough brain injury. And this can be looked at in terms of they may have had a neuropsychological assessment whilst in hospital or whilst in rehab. The degree or the duration of post-traumatic amnesia is very important. So with a serious brain injury, the patient would usually have a long duration of post-traumatic amnesia. And whether the impairment came on or was noted straight or soon after the accident, or was there a gap? And unless there's been some reason for a second lot of trauma, for example, a latent bleed into the brain, then if there is a gap, that makes us somewhat suspicious and is probably more likely to infer a psychological reaction. And to be honest, very often it's both. It's the organic traumatic brain injury and the understandable psychological reaction, both of which are important to be assessed, and that's why patients will often see a neurologist, neuropsychologist, and psychiatrist or neuropsychiatrist.
Okay, it's tricky stuff, some of these presentations, and it makes it difficult, I guess, for a case manager or lawyer to work out where best to refer the assessment. I guess when in doubt, probably the best way forward is to have a quick call with somebody like yourself to ask, whether this would be something that would be appropriate to put before you.
Yeah, absolutely. And that is something that we do and that we're happy to do. And again, this may sound a little self-interested, but often the neurologist is the first port of call because of the breadth of the specialty. So if in doubt, we're very happy to do an initial assessment and then suggest on referral to some or all of the other neurospecialties as is relevant. But again, an initial neuropsychological assessment is a pretty safe bet if we're a couple of years down the track.
Yeah, okay, fantastic. So another interesting question and a common presentation for case managers and lawyers is around back issues, spinal issues, and the question of when to use an orthopedic surgeon for the second opinion or the independent opinion versus, spinal surgeon, a neurologist. Do you have any insight that you could share with us in terms of, in the first instance, where should I be seeking that advice? Are there particular kinds of injuries that really should be referred to a neurologist for an independent opinion in the first instance? Can you help us navigate that difficult issue? Because, orthopedic medico-legals are engaged in about 30% or 40% of occasions. Potentially neurology would have been more appropriate.
So this can be a complex area to disentangle, and there probably are a larger number of patients who would benefit from an initial contact with a neurologist, in part to assess whether or not surgery is likely to portend a positive outcome, particularly in the middle to longer term. And this is based on an in-detail neurological assessment, which is really part of what our specialty is designed to do. So obviously we don't perform the surgery, but we're trained to undertake a very detailed examination and assessment, as well as be very much aware of the research and apply that to the patient in front of us when recommending whether or not surgery is likely to be successful in a patient. Now, when it comes to the actual choice of surgeon, should that be appropriate, then the broad term of spinal surgeon is appropriate, and spinal surgeons can either be neurosurgeons or orthopedic surgeons who have subspecialised in spinal surgery as opposed to, for example, peripheral nerve or brain surgery. And I would recommend that if a neurologist suggests that surgery is appropriate, then that an expert spinal surgeon is sought out for the best possible outcome.
So thank you, Associate Professor Szmulewicz, for sharing your insight today in this session around understanding the neurospecialties. That's helped us become a lot more clear around when should we refer to the different neurological specialties. Thank you so much.
Thank you.